operating surgeon we have is Dr. Anurag Mishra. Sir will be operating left eye of a 65-year-old male patient. The patient is on blood thinners for cardiac condition. NO3-P3 will be the cataract grading. Patient has well-dilated pupil. The lens implanted will be plus 21.5 diopter Hoya Impress with mini monovision. Over to the OT.
So you just heard the patient details. Without introducing the patient details to you any further, I'll just go straight into the surgery. As you just heard, we have a Vivinex Impress for this patient, the enhanced monofocal from the house of Hoya. This is the way I like to do my wounds. The side port holds the eye while the main port enters, and then you slightly extend the side port to your desired dimensions. Go to the other side and do the other side port. The patient's appearing very, very cooperative indeed. So all the 3 ports are made before even the first solution goes into the eye, which is going to be, look at the light, sir. Can somebody help me with the language, please?
Light,
so this is oculin, a mixture of intracameral anesthetic and the dilating drops. So we're one generation down as far as the implant is concerned. For this particular case, we saw the trifocals for the earlier 2 cases. We are going into the line on the cornea, please. We are going in for the enhanced monofocal for this. Traditionally, the enhanced monofocals have actually, when they came into the market, they have stormed it virtually because of the fact that they are much more economical than the trifocals are, much more affordable than the trifocals are, and yet they do the job of giving that intermediate vision to the patients, a functional one, not a full one. So that's how they differ from the typical EDOF. However, according to the definition of the AAO task force, which was formed to define the EDOFs, if you look at the definitions and the bullet points that define an EDOF, you will find that the enhanced monofocals can also be defined as the EDOF lenses. If you look at the definition of the task force, the only difference being some of the enhanced monofocals actually stretch the focus into a line, and some of the enhanced monofocals have 2 distinct foci. The Impress works on a very interesting and peculiar principle of modifying the anterior surface. Now, the anterior surface is an aspheric one which is flat, and then in the central 2 millimeters they have both convexities and concavity. If you look at the schematic drawing of the lens, the central 2 millimeters will appear somewhat like a wave to you. What it does is, since there are both convexities and concavities on the surface, along with the asphericity, which actually gives us the sharpness of focus, it produces foci both anterior and posterior to the main focus, essentially turning it into, give me CHOP please. Yeah. So I believe in operating under very, very low fluidics. The IOP stays at 20. I'm sure the parameters are not coming on your screen, but if the video camera can just focus on the machine screen a little bit, we can see the parameters. The flow rate is around 23. The IOP is stationed at 20, and the vacuum is around 450. The IP is switched on, which gives me access to the inner core of the nucleus, which I wish to chop. And this is the way you should chop. If there's any youngster watching, go on cartwheeling the nucleus, ensure that the nucleus rotates freely beforehand with your hydro, completing it, and then once you are through, take out the smallest piece out of the bag, rotate the handpiece a little bit, because Ozel works at its best when it is working vertically. The followability just increases to another level when the Ozel works vertically. So you can pronate your hand a little bit so that the Ozel starts working vertically, and then you can immediately see a sea change, a sudden jump in the followability rate. It becomes very, very followable, all the pieces. So one after the other, the pies can be dislodged from the bag, and they can be consumed with the fluidics of the machine. The IOP stays at 20 even for the quad mode. I don't scale it up. The flow rate also stays at somewhere around 25. With the excellent a manifestation of the fluidics at the machine's business end, you actually don't need to go up with that a lot. So we are through with the nucleus management. All we are left with is the cortex. The cortex also has an IOP of 22, and I use a coaxial IA just like Shri Ganesh sir. But the only difference is the tip is a little curved. It's not a straight tip, which just makes the subincisional cortex a little more accessible than otherwise would be. We'll start with the remnant of the epinuclear plate and then aspirate the air bubble. The one thing that I like about the Centurion machine in particular is that it's always a closed circuit. Once you have primed the machine, very, very rarely do you find air bubbles liberating onto the system. So it is devoid of air bubbles. However, if one or two come in, it's always a good idea to remove them before you carry on with your steps further. So after you clean your bag, the bag would be ready to receive the implant, whatever implant you're choosing, if it's a toric, if it's a non-toric. So coming back to the implant proper, as I was discussing, the posterior surface is something that is untouched with the impress. So they have kept it to impart toricity, the impress toric, which is not yet available in India, but the good news is it's commercially ready, and it's probably hitting the market soon internationally, and then it will come to India. I'm eagerly waiting for the arrival of that product, because as you know, once you start your cataract practice, you will have the need of torics more often than non-torics. So any platform, be it trifocals, be it EDOF, be it enhanced monofocals, the availability of the toric trim in that segment actually makes it more complete as a portfolio. So if you don't have torics, you're significantly restricted when you choose that particular product for your patients. So because 40 to 45% of your patients almost will fall in that category where you would need torics. Can you please prepare the IOL, sir, for me? Ready? Okay.
See, largely we do understand that giving them very crisp distant vision is very important. I just noticed that about this micro mono vision which you are planning in this particular patient. Is that so?
Yes, ma'am. Micro
So
mono vision is.
do you feel that it is needed in these EDOF lenses? If you can adequately explain that distance is more important, and anyways micro monovision more than 0.75 you wouldn't give because you would lose stereopsis.
No, even with a 0.5 the stereopsis is lost, ma'am. With a 0.5 it
Yeah.
doesn't go beyond a gross stereopsis.
Yeah.
It doesn't go to the 60 seconds of an arc benchmark that we have for our patients. So, but with an impress, just one interesting fact that I would like to share, I would not like to render my patients myopic if I'm implanting an impress.
Yes.
Because A, it does not need that. It's one of the
Yes.
most predictable enhanced monofocals in the industry, which always gives us a defocus of one diopter, whatever be the situation, and consistently gives it. Particularly after bilateral implants, it behaves so very well with both eyes being able to see and both eyes having a wonder. So this is just a moment. This is how I implant the IOL, the preloaded one, directly into the bag. Just have to turn your hand a little bit towards left while the trailing haptic comes out, and it goes straight into the bag. You don't have to juggle it around at all. I don't need this, please give me the dialer. So coming back to your point, ma'am, the impress, quite interestingly and ironically, I have in my experience actually is counterproductive when you leave a bit of myopia.
Yes.
It doesn't work very well when a bit of myopia is left. So the impress is at the peak of its performance when you leave it absolutely bang on emetropia.
Yes.
So I don't normally do a micro mono or a monovision and as it is, forgive me for saying this, but I actually do not believe in the concept of micro monovision a lot, because I think whatever you do with your eyes, they should always work cohesively, they should always work in tandem, they should always work hand in hand with the other partner of theirs. So this is the AC form that concludes the case. Thank you so much for watching. If there are any cases, I'm happy to take them. Thank you.
Dr. Anurag, that was very good surgery. Good, you also mentioned that even with this 0.75 ad for these advanced monofocals, it's still classified as EDOF. Because probably a year back there was a news going around, only if it gives more than 1.5 ad, it will be considered as an EDOF.
No,
The reason-
according to the definition of the task force,
Yes.
you need to have a 0.5 defocus at
that's all.
0.2 logmar.
Yes.
So at 66 centimeters. So according to the definition that is given by the task force, it should be. But in my opinion, a true EDOF, I mean, if you look at the clinical part of it, a true EDOF is one. Forget about the defocus it offers. A true EDOF should be the one which gives you close to N6 at 60 centimeters. That is something the enhanced monofocals usually do not offer. So the true EDOFs, which are much more expensive in the ladder, should be the ones who should be giving you around N6 or N6 parts at 60 centimeters. That's where my benchmark lines.
Definitely, but according to the classifications, these can be considered as EDOF.
According to the classification, Dr. Alan, what surprised me was there is no mention of the focus being converted into a line.
Yes,
So
yes.
extended depth of focus actually has lost its importance in the definition. By the definition, you can actually categorize even the trifocals as EDOFs.
Actually, they have,
So,
actually.
yeah, so
EDOFs
the-
with trifocal
So there are fallacies with that particular definition. I think they need to work on it and change it a little bit.
But I do agree that in his enhanced monofocal, you have to, unless the patient is really persistent, don't go for a micromonovision. But if you're doing a trifocal lens and due to some reason the patient is not seeing adequately well in the other eye, doing a micromonovision is fine. In geometrics, it's not needed because they have a light distribution concept by which you can give a geometric plus in the other eye. So we can't say that micromonovision is totally out. It has a role in some of, not with these EDOF lenses, that is enhanced monofocal. You could do it even in an EDOF for that matter. You can, you have promised near vision and some of the EDOFs do not give you that N6, then you could do a micromonovision for the other eye and help them so that one takes care of the distance and other gives for near. Yeah.
So technically speaking, if you look at the DOF curves of some of the EDOF IOS, the curve has a flat top. So even if you shift it left by around 0.25 to 0.5, you do not lose out on distant vision. That is
Yes, yes.
theoretically there.
Yes.
But practically what I have seen is, even if you are overcorrecting them by 0.25,
Yeah.
the quality of vision for distance, even if quantitatively a 6.6 is achieved, qualitatively it is not as good as we desire it to be. So I prefer to stay away from it. However, it's a personal take.
Yeah. Well discussed, Dr. Anurag. Very nice
Thank you
surgery.
so much, ma'am.